Hi, everyone. Welcome to our UC Irvine Age-Friendly Geriatric Education Tele-Echo series on mental health. Today's session is going to be focusing on suicidality, elder abuse, and neglect, and will be presented by Dr. Lisa Gibbs. This specific session in our mental health series will be focusing, again, like I said, on older adults and suicidality and elder abuse. The objectives we're going to be focusing on today are discussing how changes in mental health affects older adults in the context of suicidality, elder abuse, and neglect, reviewing different types of elder abuse, discussing prevention and screening tools that relate to mental health. Our target audience are healthcare professionals and anyone with an interest in the care of older adults. We are accredited by the ACCME to provide continuing medical education for physicians. And the CBRN also recognizes CME credits as transferable for their members. So nurses may receive CEUs after submitting their UC Irvine attendance certificate directly to their board. Many other state boards will also have a similar process. Everyone today will receive either a CME certificate of health professional certificate, which they can submit to their board for credit. Today's agenda is as follows, with welcome announcements and introductions, followed by our didactic presentation, and then our patient case and discussion, and followed by closing and reminders. Just a few quick house rules. Please be sure to mute yourself when you're not speaking to prevent background noise. Always make sure to introduce yourself before speaking with your name and location, and maintain confidentiality at all times when discussing the patient case. This session is being audio and video recorded, and so your participation confirms your consent to this recording. This project is supported by the Health Resources and Services Administration, and information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. And none of our faculty have any financial disclosures at this time. We'll go ahead and move on into introductions and have our hub team introduce themselves. But for all of our registrants, please go ahead and list your name, role, site, and location in the chat function, please. Thank you so much for joining today. My name is Mika Seville. I'm the project manager for our Geriatric Workforce Enhancement Program here at UC Irvine Health, and we're located in Orange County. We'll go ahead and move on to our hub team, Dr. Sagel.
Hi, everybody. Welcome. I'm Sonia Sagel. I'm a professor in the Department of Internal Medicine and Division of Geriatrics, and welcome.
Thank you. Camille?
Hi, everybody. Welcome. This is Camille Fitzpatrick. I'm a geriatric nurse practitioner at our FQHC in Santa Ana, and where we teach residents and nurse practitioners, and I'm a professor in the School of Nursing. Thank you and welcome.
Thank you, Camille. Dr. Gibbs? Let's see, anyone else from our hub team?
Hi, everyone. My name is Carlos Garcia, and I'm the web data analyst. Welcome.
Okay. Let's see. We have quite a few people on the line from all over the place. So thank you so much for introducing yourselves. We are going to move on into our presentation. Let me make sure Dr. Gibbs is here.
I don't think she's here yet, Nika.
Okay. 1 second, please. Sorry, she'll be on in just 1 minute. She was having trouble joining. Give us 1 second, please. Thank you.
Good afternoon, everyone. Sorry for joining late. I just had an urgent situation come up in another meeting, but welcome everyone. And we're looking forward to talking about mental health as it relates to elder abuse and neglect and suicide. Okay. All right, Nika, thank you. So I want to introduce the topic of elder abuse. We have really 6 categories. Most of you are aware of this and probably heard about this before, but I'll just briefly review each one. There's physical abuse, and that includes, hitting and punching and everything that you might consider to be, physical harm. But it also includes the overuse and underuse of medication. It also includes, unfortunately, restricting people, tying them down, and so forth. And so the category is a little bit wider than we normally think about. Financial abuse, again, this occurs in families, but it also occurs widespread scams, especially during COVID, I might add, institutions, contractors. This category is so wide that it's really hard for anybody to really get their arms around, but I'll talk about that a little bit more. There's emotional abuse, as you can imagine, that just it's really about harassing, abusing, bullying, demeaning, and so forth. This particular one in California is not reportable, and I doubt that it's reportable in many other states in this country, but it is known to be a significant category and really does it is present when any of the others are present as well. Okay, sexual abuse, I think we all understand what that is. It does happen with seniors, and it does happen in homes. It happens in nursing homes. It happens in facilities. So unfortunately, even though we can't fathom that, an older person might be sexually harassed, raped, or what have you, it does exist. Actually, we just had a case here in Santa Ana, which I read about in the paper last week. And an employee of a nursing home type facility, unfortunately, was in the middle of raping a resident when another employee walked in. Unfortunately, that other employee walked right out, contacted the supervisor, who contacted the Santa Ana Police Department, and that person was arrested at that location. The crazy part about that, though, is that that person had worked in that facility for over 3 years. And so they are looking for, other potential victims. But the sad part also is that that facility has a high rate of dementia patients. And so it may be very, very difficult, to find people that have been abused and remember it enough to even be able to report it. So we can move on then to neglect. I think we all understand what neglect is. Neglect is, really, it can be passive, can be just not providing life, including appropriate medical care, appropriate housing, medications, and so forth, and hygiene. And then self-neglect is sort of its own category, but we still include it. It is reportable to APS because oftentimes people that self-neglect have no support system and do require someone to step in and help. And again, these are folks that just cannot provide for themselves in terms of their own self-sustenance, in a hygienic manner, potentially not keeping up with her home, potentially hoarding situations and so forth. Okay. All right. So for every report of abuse, we need to remember that almost 24 cases are not reported. This is highly underreported, to the point where we really don't know what's going on. Obviously, we only know what we see. And it's been difficult for us in the field of elder abuse to really explain this, because there's an element of ageism in society where we don't really see it. It's much easier to see that child abuse is a problem, but it's much more difficult to see that elder abuse is a problem. And again, we attribute this to ageism. Okay. However, knowing that, we also know that it's very, very common, and we estimate even in California that an elder or dependent adult is abused every 3 minutes. Okay, so extremely common. This means if you are caring for patients and you have a clinic, if you see 8 to 10 patients, you should actually, be aware that you have a potential 1 or 2 patients in your clinic during that day or that half day that have been abused or are being abused. So extremely common. If we just learn how to become aware of it, we will see this and see much more that we should be reporting. And of course, all healthcare providers are mandated reporters. In California, I know there are people here from other states, so that if your laws don't match California's, it would be good to look them up. Okay. So we really want to focus on elder abuse and mental health for this particular series, and how elder abuse can lead to problems with mental health, and how mental health can potentially put somebody.
I'm doing this on my own, the echo thing. Oh. So it's not like mandatory for us today.
Hey, Chris, I'm on the UCI webinar. Can I call you back? Okay.
Okay. So we want to talk about how both elder abuse leads to mental health problems, and also how mental health increases vulnerability for somebody to become an elder abuse independent adult victim. As you might imagine, there's a lot of crossover here. So risks for abuse include dementia, especially dementia with behavioral symptoms, depression, and we'll explain some of these, loneliness. Older adults are also vulnerable to undue influence from mood disorders, including depression and anxiety. Functional dependence increases when need for caregivers, which can potentially increase the incidence of elder abuse. And also a history of abuse also predicts ongoing abuse. Now, I will take a moment to explain the photograph on the right. This was a case that I was involved with. This, unfortunately, was a gentleman who was beaten over a period of more than a year by his wife's caregiver. This gentleman had mild dementia, and we were called in not only to assess his capacity to tell what happened, but also to generally look after his general physical and mental health well-being. And so he actually ended up with chest pain one day, and so the caregiver called 911, and this is how this came to light. But this gentleman suffered for quite a long time in this situation. Now, I mentioned a couple of things are relevant to those risks that I mentioned on the left. So he did have some dementia. He did have depression. In terms of loneliness, he was kind of the odd person out in his home because his wife and his wife's caregiver were abusing him. However, there was a history of domestic violence in his marriage. And so during the marriage, he had also abused his wife. And because of his physical situation, he was somewhat dependent for care, for meals and so forth in his home. So this one case illustrates a lot of those issues. In terms of depression and loneliness, You know, we see a lot of elders that potentially have gone through a death of a spouse or are isolated in their homes, potentially isolated from family. And this of course is a setup for those who would want to take advantage to come in and befriend them. And eventually, you know, we've had cases where people have then taken over the estates and you know, the rights to the house and so forth, while isolating other family members. And so this is more common than you think, and it's very difficult, but we do see a lot of these cases. Okay, next slide, please. So what about the mental health of the people who abuse? Well, there are some threads of commonality. There can be a caregiver with their own mental health problems, whether it be anxiety or stress or depression. Depression is extremely common with caregivers. And as you can imagine, this only will be increased by caregiver stress. And we see that quite a lot. There may be a situation like in this story that I just told about the caregivers having been abused by the victim. And so then the roles get reversed. May have a caregiver with a substance abuse problem. There may be a history of transgenerational violence and family dysfunction. And caregivers may be dependent on victims for finances or housing. So we see many cases where children might move into the elder's home. They may have a substance abuse issue, they may be unemployed, and then therefore they become dependent on the victim for money and housing, and eventually try to take those over from the older person. Okay. This is not an extensive list, but these do define some common threads and characteristics of abusers. Okay. You know, and one scenario we do see quite often, again, are caregivers with inadequately treated mental health or substance abuse problems who feel burdened, resentful, potentially, providing care for an older adult who potentially has dementia, who's also physically combative or verbally abusive. And you can see how you can have elements from the caregiver, from the victim, and from the situation that all really, you know, define a situation which is really toxic and breeds elder abuse. Okay, so let's focus in on depression and how depression may relate or interact or be caused by different types of elder abuse. I add a painting. My favorite painter is Van Gogh. Of course, this is Starry Skies. And of course, he himself had depression throughout his life and possibly other mental health disorders. I always like to add some art to what we're doing. Okay, next slide, please. Okay, so let's just take a moment and think through types of elder abuse and how mental health can be related to each type. Okay, so in terms of physical abuse, you know, when we see people that are physically abused, of course, you can certainly imagine that they're in a situation where they are victimized. They're afraid potentially for their lives, afraid of being harmed. And again, it's very easy to see how this can exacerbate a situation of dementia or anxiety. And I would also say that just an older person being depressed or being anxious can be a setup again for people to come into their lives and take advantage. Emotional abuse, again, you know, is a setup for one is being emotionally abused. They're being demeaned. They are a victim. And again, these abusers are very manipulative, whether they know it or not. They come into a situation and work to really lower the confidence and increase the dependence upon them. So you can, I mean, it's very, very easy to see how somebody who's being emotionally abused would have worsening depression, anxiety, And somebody who's really at the foundation depressed can be a setup for somebody coming in to do this. And emotional abuse, as I mentioned, is really, when you have one type of abuse, you often have multiple types of abuse. So whether you have physical neglect, sexual, financial, etc., emotional abuse is likely to be there. In terms of neglect, again, this is somebody who's being neglected, who's not being cared for. We've seen cases of extreme neglect where people are just relegated to the back room. And once we became aware of a situation, we realized that, they're not being taken care of for hygiene. They have pressure sores because they're not being transferred or helped to get up if they have physical limitations. And a lot of times we become aware of these cases because of severe pressure sores, emaciation, people are not, getting the nutrition and so forth. And obviously this seems like a very hopeless situation. Again, rift with, a lot of mental health consequences such as depression, anxiety. The rest, I think we can say the same for the rest. Although I will say that, once somebody's taken advantage of financially, it's possible that they could lose their entire life savings, including their home, their estate. Somebody may take over the trust, and this is just absolutely devastating for people that have saved, worked their whole lives, and it's really unforgivable. But we help victims deal with the aftermath of this. And it's almost too much for people to overcome. Okay. So I think, obviously the healthier somebody is in terms of mental health and well-being, I think it's harder for someone to come in and take over their lives. So that would be one pearl to take away. We want to empower people and provide them with self-confidence and provide them with the safety measures so that those that would take advantage don't come in to do so. Okay. So what can we do? How can we be aware of the elder abuse that we know are in our clinics right now, every day? Well, we can start with asking. We've actually added a screening question in our annual wellness exam, which basically says, is anybody forcing you to do anything that you don't want to do? Or is anybody caring for you, making you feel uncomfortable? And this is just, as I said, it's a part of our annual wellness exam. There's some literature on screening tools for elder abuse, but there's no consensus about really what to use. Or if you look at the national guidelines, none of them really agree on this topic. So we've just taken it upon ourselves to start asking. And truly, it's amazing what people will tell you when you directly ask them. So along with that, it's important to really ask about depression and anxiety, because again, if you think about depression and anxiety as being a foundation for which elder abuse can be born from, then we really want to know about depression and anxiety in the context of their safety and their ability to be resilient against elder abusers. Now, we have had several patients throughout the years in our clinic, elder abuse. And as I mentioned, one of the risks is a history of abuse. So basically, when we speak with patients about, their situation, we really want to avoid re-traumatizing them. And so we really focused on a method of trauma-informed care combined with motivational interviewing. And I'm going to explain that a little bit more in the next slide. In terms of reporting, as we know, we are healthcare providers and we are mandated to report absolutely here in the state of California. And for people in other states, again, please look up your specific reporting laws and requirements. And of course, we want to be an advocate for our patients. We want to understand that once they become a victim of elder abuse, this is really affects every single area of their life. And so we need to sort of keep that in mind as we work with them to treat diabetes and hypertension. I mean, they may not have, they may be depressed, they may not be taking their medicines, you know. So once people have their lives taken over by an elder abuse incident, depending on how severe it is, it really does affect every aspect of their lives and their being. Okay, next slide. And I mentioned trauma-informed care. Some of you may have heard of this. There are 5 key areas to this. Safety. So once we understand that a patient is a victim of elder abuse, this would go for child abuse or domestic violence or any of this. You know, of course, we want to avoid re-traumatization. So we want to make sure that patients know that this is a safe place to be. We are safe to speak with, and their privacy is respected. Except for the fact that sometimes we have to let them know that we will be reporting to APS because we want to help protect them. Choice. We want to make sure that, you know, victims and survivors understand that they have choice. They have rights and responsibilities. Like, we are not going to come in and take over their lives. And I think that's one of the real issues with reporting to APS, and that's a barrier. Because some healthcare providers believe once they report, somebody will be involuntarily taken from their home and placed in a facility. Hopefully this belief is changing, but I think that thought is still out there. And the truth is that once APS social worker goes out to a home, they actually ask to speak with the client, right? And if the client refuses, the social worker goes away. So only in very, very extreme situations where somebody really does not have capacity are they potentially moved from their home. Collaboration. So we want to make sure that we're in a shared decision-making process for individuals. For instance, there are a lot of parents that are abused by their children. The children may be living in their home. And we'd like to see these elders get to a point where they either, you know, tell their children to leave, or even have a restraining order against their children. But obviously this is a very complex situation with a lot of family dynamics. And so sometimes mental health experts work with the victims of elder abuse for quite a long time before they can get the self-confidence, or even an awareness that they're being abused. Because if you're used to the situation where you're constantly being demeaned, you may not have the perspective to come out of that and understand that you are actually being abused. So that's a lot of what mental health workers work on with folks, to sort of help people change their decision making. And trustworthiness. Of course, we always want to be respectful and have professional boundaries. And at the height of all of this, we want to empower the victims of elder abuse, so that they can make choices that provide for atmospheres that allow them to feel validated and affirmed, so that when we work with people, whether it's in our clinic or in our elder abuse forensic center, we've actually had every agency trained in trauma-informed care, so that at every contact with every agency and representative, they are treated with this approach, so they're not, as I mentioned, re-traumatized at any point in the process. Okay. Fairly quick overview on elder abuse, because I was also given the topic of suicide, 2 very heavy topics. So I will now turn to suicide. But we thought they were both important to include in the series. Okay. All right. We mentioned a little bit about suicide risk in the beginning, and I'll just repeat some of these risks briefly, and then talk a little bit about some of them in more detail. We know that older men more frequently complete suicide than women. We know that in older adults, among those who attempt, more are more successful than in other age groups. Firearm availability doubles the risk. So this is why also in our annual wellness exam, we ask if you have access if you have firearms, are they locked up? If you have firearms, are you safe? So it's an interesting situation because we didn't want to be judgmental about this, and I do know in certain states in this country, this would not be an easy thing to add to an annual wellness exam. But the importance for us, is that if we're dealing with a patient who has dementia or depression or a history of violence, or a very, very difficult social situation, we know that guns are in the home and they potentially are not locked up or safe. That just raises a red flag for us to kind of look out for that whole individual as well as family. So when we put that information together with other information, it helps us care for our patients. We know that disruption of social ties increases the risk. Very importantly, in the first year after the loss of a spouse, we know that the suicide risk is highest. So again, this allows us to be aware that when we have a patient who's just lost a spouse, we need to be especially vigilant. There is some research showing that with certain physical illnesses, the suicide risk increases. And this particular literature notes that people early in end-stage renal disease or starting to think about dialysis are at increased risk. And those that have more functional impairment and those with substance abuse issues are at increased risk. Now, next slide, please. So we know that older men, specifically older white men, have the highest suicide risks. And what I will say is we probably don't know the extent for different ethnicities and cultures because we don't have the research, but I did want to dig a little bit deeper into these suicide rates and found a specific difference between the rural and the urban suicide rates. So what you see before you is a graph of rural and compared to urban suicide rates in females. And if we look at the latter half of the graph for patients over 65, we see about 5 per 100,000 deaths. Actually, the rates between rural and urban aren't very different, okay? Although it looks like after 85, the rates in the urban areas tend to be a little higher, okay? Now let's compare this to males in rural and urban areas. Here you can see an absolute difference, okay? So number one, we know that the suicide rates increase after 65. That's very clear here in both rural and urban areas, but take a look at the rates in rural areas compared to urban areas. So for those of you, in more rural areas of the country, this is extremely important to note. And compared to the rate of 5 per 100,000 in women in these charts, we actually see that we're looking at, anywhere between 20 to 60 per 100,000. So the rates in this is from a HRSA website. The rates from male to female, we're really looking at, an extreme ratio, maybe a 5 to 6 of men to 1 to women. So if you're in a rural area, you know that you have older men that are living alone, potentially with firearms, and they're sort of isolated from the world. You want to pay special attention to these patients when you see them. Okay, next slide, please. So I just wanted to illustrate one case study from our work, which really confirms what we're seeing with these other statistics nationally. I took a look at elder deaths in Orange County from 2016 to 2018, okay? And found between those 3 years, actually it should say 219, not 2,109, but we had 219 deaths by suicide in Orange County over those 3 years. Our ratio for males to females was 77% to 22%. The average age was 75. And the method of suicide by far was firearms, again, asphyxia and overdose with, those were the top 3 that I wanted to mention. But again, that use of firearms in an older older adult, especially male, who's depressed and isolated, living alone in a rural area is definitely someone you want to really watch out for. So I then took a look, we then took a look with the help of a graduate student to look at where most of these suicides are in our county. And I briefly mention this because you'll see the darkest pink area, like in the lower right, that is Laguna Woods, and that is an area which is only populated by older adults. So the density of older adults is there. It's not entirely surprising that we would have more older adult suicides there than in other areas of the county. But if you look to the left, just at the edge of the black box, you'll see Huntington Beach. This is something that we did not expect, and we don't know exactly why, but we have some theories, you know, which actually amount to the fact that there's a lot of retired military and police officer area living in that area. A lot of folks potentially ex-military and so forth with PTSD. Again, probably a lot of firearms availability that in that area. So on a community level, this is something that we are also very aware of. Okay. Special attention to suicides in facilities. Now, when I started looking into this, I thought, well, suicide rates in facilities are probably lower than those in the community because, I mean, look at all of the oversight in facilities, right? Absolutely wrong. The cumulative incidence of suicide in facilities is comparable to community rates, okay? Again, the same risk factors and demographics relate to facility suicides, mostly white race, male gender, history of suicide attempts, and mental health problems. But what's interesting here is that they found a higher risk in anticipation when people anticipated having to transition into long-term care facilities for themselves or for their loved ones. So let's say we have, you know, a gentleman and wife living in the community, but one of them has dementia to the point where they need to move to a facility. It could either be that individual, if they're not as, you know, so advanced in their dementia, or their caregiver that contemplates suicide because, you know, one's moving into a facility, the other's left at home after maybe 30 to 40 years of marriage, or the one going into the facility just, you know, can't face that change. So that is also something we can look at in clinical practice. People making those major transitions from the community into those facilities. Also, the literature really talks about, you know, how residents feel in these facilities. And we really need to empathize with this. Residents in facilities get to know other residents' facilities. They are very sensitive to people losing their function, getting worse, becoming more dependent. And oftentimes residents of facilities will also talk about death, okay? It's not uncommon to talk about death, but overall, these researchers found that the staff are reluctant to engage in conversations about death. So they really couldn't get to the bottom of whether somebody was just thinking about death or whether they actually had an intent to potentially commit suicide. So, you know, it really illustrates that staff in the facilities have the charge to be, you know, wonderful models of care that really instill hopefulness and decrease the isolation and provide meaningful activities in these facilities. So there's a lot we can do once we know really what the risky situations are. Okay, next slide, please, is prevention. So again, we want to understand these risks because we want to understand when our ideal points of engagement are potentially to catch somebody who's considering suicide. I think we've all heard that a majority of suicide completers visited their primary care physician in the year before suicide. And even more so, there's other data that says that 45% will have seen their primary care provider within the month before their death, while only 20% of them have seen a mental health professional in that period of time. So we are the front lines, and we really need to be the ones who are aware of this. Again, I want to reemphasize that we should also consider long-term care patients as people that contemplate suicide as well. Focus on the transitions and absolutely focus on isolation. Okay, and the last slide, screening. So I think we're all familiar of different screening measures like the PHQ-2, where positive leads to PHQ-9. If you're not, please look that up. That's one of the more extensively used screening measures. But really, people talk about, who should we screen? Well, clearly we're going to screen for PHQ-2. And we've added that to our annual wellness exam, as most of you probably have. But the literature also shows that, we shouldn't just focus on people that are diagnosed with depression, because clearly there is a subset of people who commit suicide who are not diagnosed with depression, and some are not considered depressed. Okay. So, and, we could talk about that for a long time. But what we do know, and this is key, those people that ultimately decide they want to commit suicide and their minds are made up and they're not looking for people to change their minds, they're not particularly crying out for help. Those people that have ultimately decided that this is what they're going to do will not say. We won't know. And we had another case like this earlier in this county during COVID, where a gentleman and his wife made their plans. I think one of them had some mild dementia. They were isolated, as most are, but then again, they had a very supportive family who were trying to drop by, bring them groceries and so forth and so on. Well, they made a plan and they went to a nearby hotel. They rented, they had a room for the night. They brought, medications that they could overdose with. They left notes. They left a tip for the hotel staff who would have to find them. And they both just committed suicide. So, the family was completely astounded. There was no evidence of depression. There was no evidence that this would happen. And we talked to our mental health professionals and said, yeah, this is the kind of case where people have made up their mind. They've made extensive plans and they're not looking for anyone to change them. So you will find these situations as well. But what I wanted to point out too is that there's some researchers in Japan who studied the PHQ-2's ability to predict suicide. And it's actually not the best. The best way to really screen for suicide, it turns out, is to really frankly ask, are you considering suicide? And that's a question, the last question on the PHQ-9. So that turns out to be very specific and sensitive. So even if, your PHQ-2 is negative, sometimes you really want to, if you feel like you should probe a little further, you should really frankly just ask, do you not seem like you're depressed, but I ask all my patients about suicide because it's a big issue. Have you considered suicide? You may not want to do that with everybody, but the research is showing that if we did that more often, we would pick up people who are negative for the PHQ-2 but are considering suicide. Okay, so I'm going to end there. Again, a quick oversight over suicide and elder abuse, and I know we have a case. So Nika, I'm open to questions, but I don't know if you want to entertain any now or if you want to wait till after the case, or you can put them in the chat as well. We'll be watching the chat.
Yeah, we'll go ahead and put it in the chat if you have any questions, or we can ask at the end of this session. But we'll go ahead and move on into our case. Thank you so much, Dr. Gibbs. We do have Nikki Friedberg, who is one of our clinical social workers here at UC Irvine Health, who's going to give us a quick overview of her patient case. So I'm going to go ahead and share my screen. Nikki, are you on the line?
I'm on the line.
Okay, 1 second. Let me share my screen here with your case. And if you can give us a quick overview of this patient.
Yeah, so this patient is a 69-year-old female who came to the attention of myself and the nurse practitioner I work very closely with within the ACO on a tiny but mighty two-man dyad. And we oftentimes reach out after hospital discharge to just assess how the patient's doing, meet any of their needs, connect them back to clinics, and just kind of do a broad overview assessment. And this patient was admitted back in April of 2020. And we just kind of opened the conversation to them to see how they're doing. And my primary focus is social determinants of health. And I think the primary reason for this admission was anxiety and crying is what she noted, scared and crying. So she has a lot of admissions related to chest pain, shortness of breath, and anxiety. So a lot of psychosomatic symptoms going on. Her other notable medical issues are hypertension, hyperlipidemia, COPD, CHF. Unmanaged diabetes is probably one of the most prevalent conditions, and she has a history of colon and endometrial cancer. So when we spoke to her, she noted she was scared and crying, and she was anxious, and her visit was related to her anxieties related to COVID-19 societal stressors. And around this time, we were taking a bunch of calls like this. And it was a difficult time for both of us. But, you know, with that, my first thought, as Dr. Gibbs mentioned, is safety and suicidal ideation. And, you know, I explored that. She denied it. She also noted that she has a talk therapist. However, she couldn't tell me the therapist's discipline or the clinic that this therapist came from. She did have protective factors of her daughter and her Catholic faith and a close friend. She also had a psychiatry referral in the system, which she noted she would follow through. And I inquired as to any barriers, and she did not indicate any, although she did have a history of missed appointments and not connecting with providers. However, you know, at this juncture in time, I'm really trying to build rapport and align and not probe too deeply into anything that could be off-putting. I assessed for financial strain. She said she's retired and receives Social Security, but money's tight. She also receives IHSS from her caregiver / roommate and her daughter. She has mobility issues. She has a motorized wheelchair. And she attested that her daughter and her roommate assist in ADLs, medication management, purchasing and preparing of food. And that was the overview of social determinants for the first call. And we asked for permission to speak with, and the nurse practitioner provided a wealth of information on diabetes management at this time as well. And she noted she didn't have healthy food at her disposal because money was tight. So I coordinated with some community resource and was able to get food boxes delivered to her over the course of the next couple months. And on this initial call, we asked to speak with the patient's daughter, to which she gave us permission, because we try to collaborate with family when it kind of appears that patients having difficulty managing all their comorbid conditions and are down and out emotionally and things of that nature. So we spoke with the daughter. She seemed like she very much cared about the patient, even inquired about how to fix patient's CPAP machine. I gave her the information on the vendor name and how to consult on the repair. And then we connected back with the patient. Oh, and also on that first call, as patient noted she was lonely and kind of down about COVID, UCI around this time launched a fantastic program called UCI Assist, in which medical students and nursing students reach out to patients just for some friendly chit chat and connection. And she agreed to that referral. So we called her back to let her know that that would be taking place and a student would be reaching out to her. During this follow-up call, her emotional volatility was pretty high and she was anxious and crying and noted she couldn't calm herself down. So I engaged her in deep breathing exercises to teach her how to self-soothe and ground herself, and she did that. She said that was helpful. She also attested to learning meditation, which helps her as well. And then around May 2020, because she has persistent issues managing her diabetes, this whole time. She went to the ED with a blood sugar level of 633, which I think at this time the nurse practitioner triaged to the patient's PCP, and that was the best course of action at that time. Over the course of May and June 2020, she had multiple attempts to reach psychiatry, cancel with psychiatry. Again, I'm trying to build rapport, assess for barriers. She's noting that she didn't feel well, this, that, and the other. Around this time, inpatient social worker also files an APS report about neglect or self-neglect by the daughter, to which patient didn't attest to. She only spoke, highly of the daughter, and in fact, a lot of anxiety and concern because the daughter was working full time and also contracted COVID eventually. I'm not sure exactly when along the timeline, but that played into a lot of the patient's anxiety as well. Also, throughout this entire course, nurse practitioner and I are closely attempting to manage patient with PCP, and she is intermittently attending PCP follow-up. And, in November of 2020, we follow up as well, again, post-discharge, and I work to motivationally interview her about what matters to her to see if we could get her to align more with being compliant with what her medical team's recommending in terms of diabetic management. She also sees a health coach in cardiology and was being managed by a diabetic, I don't know the exact title, but nutritionist within the endocrinology department too. And she noted her main motivating factors are her family. And, she really appreciates the support of her roommate. And I asked to connect with him to see if we can enlist his support to connect with psychiatry. And she agreed. However, again, she's intermittently crying because she's tearful and anxious. So it's a really interesting fulcrum point that I'm trying to balance on, trying to motivate her, push her, assess her barriers, but not push too hard to where I lose that rapport and she no longer wants to partner with me in her care. In February of this year, I received a referral from a medical assistant in the patient's primary care clinic, noting that she wants to speak with a social worker. And because of the high volatility of her emotions, I called her pretty quickly. There was no answer. I left on the voicemail to, call 911 or go to the nearest emergency department if there is an issue, because I know she has a history of really high blood sugar levels. And, emotionally, if she was considering self-harm at this time, to which she did not disclose to me in the past, I wanted her to know that that's the best and next course of action. And then later on in February, I received outreach from the coordinator for UCI Assist program, noting that she conveyed potential, verbiage that could be perceived as suicidal ideation to one of the students. So I called that day to assess. The patient noted that, she completely denied this and noted that in the past she contemplated it, but, since surviving cancer, that this has not been an issue. She's just very down and depressed. Provided additional psychoeducation at this time on how psychiatry may be able to best support and to continue seeing her therapist, to which she said she got a new therapist, again, couldn't disclose the clinic. And I also talked to the PCP at this time to see if it's appropriate to put in another psych referral, because I think the other one was closed and she was going to visit the PCP soon. So PCP agreed to do that. And then most recent visit, I actually think there might be one today, but on the 1st of March, she saw the PCP as well. Some of the indications from that visit were, continued leg swelling and high blood pressure. And that brings us up to today, basically. And the one psychotropic medication I saw that she was on was duloxetine, 40 milligrams, and that's my general overview. So my main question to the group is how to, engage her a little more, to motivate her to see psychiatry, I guess, or how to best manage her emotional behaviors, and also manage a bunch of her comorbid medical issues that coincide with the anxiety and depression. There's just a lot going on. I think it overwhelms her. and how, I guess, engage her to be more of an active proponent in her care.
Thank you so much, Nikki. It's definitely a comprehensive case, and let's discuss. I know we only have a few minutes, but does our hub team or any of our folks have anything to add or ask Nikki?
I know, Nikki, that, you know, it's really important for you to be collaborating with the primary care provider as well, so that everybody's on the same page. And it's really fortunate to be able to have a social worker that can do this sort of work. So I think people that don't have these types of resources, you know, maybe the best thing to do is just to reach out and understand where those resources exist in the community, and find those resources that will actually collaborate and partner with primary care doctors and providers.
Yeah, I feel very fortunate to be kind of consultative and at the central hub, working alongside a nurse and building rapport with a bunch of PCPs and other ancillary providers that really support me and I support them. And, you know, bilaterally, we're really able to provide pretty robust care. I feel really fortunate.
Yeah, and I'm just sensitive to the fact that not everybody has this types of support around primary care. So I guess the ideal would be to be proactive in understanding who you can partner with as well.
Hi, this is Nicole with Share Ourselves here in Orange County. I just wanted to add to that. It is very important to know your resources, but it's also very important to know, I don't know how it is outside of California, but here our mental health resources are very taxed. So my recommendation is just get real comfortable asking these questions, because you are going to be the main point of contact for these patients, and you're probably going to discover something before they ever even get into a mental health provider's office.
Thank you, Nicole. And anyone else want to add to Nikki's case?
Nikki, this is Sarah Campbell, one of the nurse practitioners. I would just say, I think with this case, you know, she's got so much going on. There's so much you could do, right? It's almost too overwhelming. Where do you start? But I think this is where motivational interviewing really comes into play, and just really finding out for her, what is her internal motivation, what bothers her the most as far as where you start, right? Because at the end of the day, we can't make the patients do anything that they don't want to do. Now, agree, you know, obviously when they're so severely depressed, sometimes getting them to do anything is difficult because they're so depressed that maybe that anhedonia, getting dressed for her is complicated. But I would just meet her where she's at, find out what bothers her most, whether it's symptomatology with her comorbidities, or, you know, what is that internal motivator? What does she want to do that she's not able to do because of her diabetes or her depression or her shortness of breath or whatever, and find out what she's willing to do. You know, find small baby steps, you know, and work with her as a shared decision maker. You know, compromise, and just, I guess, use those motivational interviewing skills. I think this is where we have to remember that we're not, the onus is not on us. We don't have to solve this problem, right? The patient really, at the end of the day, is the decision maker for themselves, and they're the ones in the driver's seat. So that would be my biggest piece of advice here.
Yeah, thank you. Yeah. She did say that it's the most motivating factor, and she does want to improve her diabetes. It's really just bridging that, assessing what motivates her, and it's having her actually engage in action-oriented tasks to achieve what she wants.
Yeah. And sometimes it's teeny little baby steps, right? Like just something small.
Totally.
It is, yeah. And sometimes, you can bring it up, but people don't want to realize or even self-acknowledge that they may be depressed and at risk for suicide. And that, you're right, I mean, that can take a consecutive number of appointments to really get to the point where they can talk about it and think about therapy or treatment.
I know we're out of time. Does anybody have anything else to quickly add in? And Nikki, were we able to kind of answer your questions?
Yes, thank you.
Okay, thank you so much. Let me just quickly wrap up this series. 1 second, please. Okay, so just as we close out, just want to remind you that if you do want CME credits, to please fill out the form that we'll send you after this presentation. We also do have session evaluations. If you have the time, please go ahead and fill those out as well. And as a reminder, our last session in this series will be taking place in 2 weeks on March 19th, and we'll be focusing on what matters most to your older adult patients. And we'll be sharing and discussing as a panel a few patient stories revolving around this topic. So we hope you'll all be able to share your stories as well about how you've incorporated patient goals and wishes into their health plan. And again, for example, that's if you've helped a patient recover from a stroke, for example, and move back home, which is what matters most to that patient. What steps did you take with the care team to incorporate those wishes? How do you best have these types of conversations with your patients? So if you've had, so we'll go ahead and hope that you'll come prepared for that session, and we'll send the case template as well after this session. And again, our next series will also be launching in May, same time of the day and week, and we'll be focusing on chronic conditions in older adults. Some topics that we will be covering are COPD, osteoporosis, hypertension, diabetes, and more, and why and how these things are different in older adults and how to treat. So we'll have more information about that series as May nears. So keep an eye out for that. But anyways, our session's done. We'll go ahead and send you these slides in a few minutes. Thank you so much. And if you do have any last minute questions, please don't hesitate to type in the chat, and we'll be sure to get back to you via email. Thank you all for joining us today.
Thank you.
Thank
Bye.
you.
Thank you.